This is Focus on Your Health. It's brought to you by Kingman Regional Medical Center in historic Kingman, Arizona. I'm TG Lafredo, and this week I'm coming to you from KRMC's Wallapai campus. I'm at KRMC Physiatry, and my guest is Dr. Thien Ngo. He is a physiatrist here. Dr. Ngo, welcome back.
Thank you so much for having me, TG. Great to see you again.
It's great to see you. It's great to visit you here in the office. Thank you. I asked you just before we started recording, you're about to complete 13 years here at KRMC.
Yes, sir.
How's that possible?
Time went by fast. Love it here. Got out here from residency. Been serving as a medical director for 8 years until COVID hit. So we're trying to restart the program again. And then after that, I think this is our, I would say, fourth or fifth meeting together, right?
Yeah, we've done a few of these.
We have a history together over 10 years.
Yeah.
You look great. I think younger and more vibrant each day. What's the secret?
Yeah, I'm definitely not younger, and I'm definitely not more vibrant. But thank you for lying.
No, I'm not lying. I'm jealous because I have new staff working in the office, so they look at the picture when I first got out of Kingman, my picture.
Did they give you a hard time?
They look. No, my nurse told me, and that picture looked like you're 25. I think over the 10 years I aged a lot.
Well, thank you for the egregious flattery. And let's begin, for listeners unfamiliar, what is physiatry?
Physiatry is more a branch of functional medicine. So we cover anywhere from, unable to walk due to an acute injury like a sprain of an ankle, a small fracture, to a severe like a spinal cord injury, a stroke, a brain injury. So we cover everything in between. So we're trying to help the patient to regain a functional status for either walking, breathing, eating, swallowing, using their hand, using their feet. So basically regain the functional recovery, I would say.
Yeah. I often think of, when you talk about that, I often think of people who are recovering from stroke and different conditions that tend to affect older folks.
Yeah.
Are your demographics generally older folks or not necessarily?
Yes. Yeah. So a little bit of what I do, I am dual board. So I said that not to boast about, but I just want to focus on the primary board. I deal with the functional medicine. So I deal with stroke, brain injury, debilitating, functional loss due to like end-stage cancer, organ transplant, severe chronic condition. So I practiced that when I was doing the ARU, but now I just mainly do covering for some of the biggest hospital here in Kingman. My origin, I do electrodiagnostic medicine. That's my second board. Right. So I basically, for me, is something, my special interest. I test for the nerve, the speed of the nerve, the side interaction for the patient to see what else we can do to either slow the progression, reverse it, or have a better understanding of what's going on to help them.
Yeah. I do want to talk about the role of technology in your work. Tell me a little bit about nerve conduction.
Yeah, so it's a technology. I think it's stemming around in the 1800s, if I'm not mistaken, and it has been evolved over the years. So basically you use electricity to test for the speed, the size, and interaction between the muscle and nerve. So that's two parts. The first part is a nerve conduction study. Think of it as I use a TENS unit. I put a little pickup and I send a signal to look at how fast the nerve travel. The analogy would be, or similar concept is if you 8th grade, remember you're testing for the frog legs. When you do a stimulation, you alter the potassium and sodium channel. You could create a electrical current, and I measure that. And so the speed and the size, usually fast and big or healthy, slow and small or unhealthy for the nerve conduction study part. And the second part, I use a thin filament, meaning a very small needle, like a diabetic acupuncture needle, to insert into the muscle, look at interaction, because the nerve innervate the muscle. So when the signal gave me back, it's dependent on the feedback, it will review what kind of condition. Is it a muscle problem, a nerve problem, a combination of both? So that's what I do. And everything is peripheral, meaning everything outside the dorsal root ganglion, meaning the little yellow bulb coming out of your spine. Everything in between, like the brain and the spinal cord, will be central nervous system. And usually I follow the neurologist. Like case in point, stroke. brain injury, spinal cord, Parkinson, cerebral palsy. So those are more central nervous system.
Right. When you're talking about monitoring the speed of nerve conduction, what might an example be? The sort of numbers you're looking at, what would represent something that's normal and quick versus something that is delayed?
Yeah, so we have a parameter for that according to the American Academy of Neuroelectrodiagnostic Medicine. So everything by the parameter that we train. So I put into the simple usage term. Let's say, one of my construction worker using the jackhammer for a long time. Now he couldn't feel his hand anymore. And that can affect his job and his quality of life. So I will measure for the speed to see I would test for the sensory nerve, the motor nerve, and the muscle, and to determine severity. So to see what we do now. Are we bracing you? Are we giving you medication? Are we doing injection? Are we doing surgical release? And I'm very grateful and appreciative and honored to be trusted by our surrounding orthopedic surgeon here, from Phoenix to Vegas to Flagstaff to Lake Havasu and Kingman too, to allow me to test for them. And you come in, let's say you have a wrist drop due to a brachial plexus, and you roll over accident, sit belt pull on your shoulder clavicle, injure the brachial plexus, now you have a wrist drop, or versus you have a nerve pinching in the neck due to like a joint collapse, or like a foot drop, meaning you're unable to walk, you drag your feet, you fall all over the place due to diabetes, nerve pinching in the low back, commonly L5. So I'm able to test for all that to kind of see the next step. And I'm saying not orthopedic, but all the specialists and all the primary care too. So think of me as more like the facilitator in between to help. And I understand different team, they serve the patient. We are a small town, so very high volume, very fast paced. And I'm fortunate enough to be able to do the test. I do the test myself. Some office might have tech, there's nothing wrong with that. I do the whole test myself, so I have a time to talk to the patient during the testing time to kind of know more about them. So I will spend roughly 15 to 45 minutes with you, depending on severity of the case, to gather the data and draft a report for you, and then see what's the next step to do.
Well, speaking of the surgical team, you've alluded to the collaborative nature of your work. Tell me a little bit about the people you work with on a regular basis and how you take a patient from the initial visit to the next steps.
Oh yeah, definitely. So let's say if you have numbness or tingling, you wake up, with a numbness, let's say common cases in the hand or in the arm. The first thing you do is you go to the ER thinking, okay, is this a stroke, a heart attack, or what is going on? So they do the workup, they deem it's not, a stroke or heart attack, and then they will send you to your family doctor. When you see your family doctor, they will say, okay, let's send you to someone in the physiatry or neurology, and in town, let's send you to Dr. No, and then you come and see me. I'm pretty efficient. I don't drag the visit out. I instead of doing a consultation and then set you up for the test, bring you back for the test, I go straight because I know money, time, and energy are important for everybody. So I try and expedite the whole case. I do the consultation procedure in one shot. I'll give you my first impression. I bring you back so we can be transparent about the result. It's dependent on team. Some provider, they are comfortable with going over my report with the patient, which is great. If not, I'll tell you in person and answer the question for you. And I will tell you my recommendation. And then I will let you decide the next step. Typically, I do the referral. Let's say you need to see orthopedic surgeon, you need to see a spine surgeon, you need to see pain management, you need to see neurology, rheumatology. So we usually that's the most general route. And a lot of time, neurology want to confirm something, rheumatology want to confirm something. They might send the patient to me for the test. And this is only 20%. So my routine speech with the resident, teaching the younger resident and the patient is, it could be a bone problem, a muscle, tendon, ligament, nerve, or vessel. What I'm doing for you is purely physiology. How fasting travel, are they stable or not? Simple question. I make things very simple myself. I'm not smartest guy. So I
Oh,
keep thinking,
please. Oh, boy.
no, I'm not, and I say that, sincerely. So I keep things very straightforward to make it easy for myself to understand. So 20% is the physiology, 20% is more the anatomy portion, where things are in space, like X-ray, MRI will review. So 60% is basically coming from what the patient telling us. And we base on that. Because sometimes MRI came back negative, patient telling us we don't see anything from the nerve test. So is it fibromyalgia? Is this a chronic pain? Are they going through something where they actually asking for help versus something you can see like physical or you can see from the anatomy and the physiology standpoint?
Dr. Ngo, do patients come to you by referral only?
Yes, most of the time. The reason it's by referral is to protect the patient financially, because a lot of time with the insurance, I want to make sure financially you don't get into any difficulty after I'm seeing you, and then you go through the whole review, denial back and forth. So I just want to make sure that's taken care of, because looking from both sides, I can be on the insurance side, and then so the thought is, if you have this issue, why don't you go to the primary care first? Why you go straight to Dr. Ngo? So that therefore the referral is meant to assist you in making sure you don't deal with the financial issue 6 to 12 months later, after you seeing me. So that is just something I want to do for the patient and community.
And I gather that a significant portion of what you do deals with counseling, deals with helping patients when we work through a new injury, a new illness, and people experienced diminished capabilities, diminished mobility. There's a medical side to it, but there's a psychological side to it. Do you find yourself kind of coaching people through that?
Oh, yes, definitely. I see one of your questions here. What drew you to this branch of medicine?
Yeah.
So to be straightforward, I'm your cheerleader.
Yeah.
So case in point, patient have severe spinal cord injury. They become quadriplegic or paraplegic. Mm-hmm. A lot of thought going through their head. Working gentleman who has 4 kids, wife or some surgeon, now they losing part of themselves functionally, but at the same time, they losing their life. What happened to my relationship, financial, the social aspect? And obviously you'll be inpatient with me. And as I'm there for you, I slow down, I stop. You can tell I talk fast, so but I slow down, and we create a bond where, to me, I felt like at that point, for anybody, including myself, we are drowning. We don't know what's going on, and I'm there as your cheerleader to reassure you this happened before, and this is the next step. So I talk to you. I see you daily. I see what else going on. How's your bowel bladder doing? Are you depressed? How's your pain? Any wound? What your labs look like? Any issue with your organs? Case manager will be involved. And then after that, all the, let's say, inpatient-wise, all the paperwork, family medical leave, paperwork fill out, and I pull out the resources. What's your discharge planning? Or you have all the equipment, the wheelchair, when you get home. It's gonna be hard to reintegrate you back into, quote unquote, the new life, the best I can. And I follow you outpatient, like that's what I do here for Kingman and in Vegas as well. That's what we do, help the patient to reintegrate after the big loss.
If you're just joining us, this is Focus on Your Health. I'm T.G. Lafredo, and this week I'm coming to you from KRMC Physiatry. My guest is Dr. Thien Ngo. He is a physiatrist, a doctor of physical medicine and rehabilitation. And Dr. Ngo, after a major surgery or after a significant accident, patients often have to make modifications in their home environments, how they live, how they get around. Talk a little bit about that, and if you're part of those conversations.
Yes, so inpatient part after significant functional loss, a lot of time you work with PT, OT, and potentially speech every day, 3 hours a day, 5 days a week in an inpatient setting. And they evaluate you based on the FIM score, functional assessment score, to see how much you're able to do. And if your score is low and you reintegrate back home, they probably do a home eval Like I think PT and OT, physical therapy and occupational therapy, go to your house, look at your surrounding to see whether there's a safe discharge or not. Let's say you are newly paraplegic, how you can get to the house with steps. So those are the things we tend to resolve. Or like if your bedroom is upstairs, and now can we move it downstairs? Or like what more can we do to make it appropriate and then as functional as we can to reinsert you back into like the new life.
I want to return for a moment, if we could, to the topic of technology. And I'm just thinking, we said you're completing 13 years here at KRMC. You've been in the game for a while. I wonder, as you reflect on your career to this point, how technology has changed, how you're using it maybe differently, or is it still pretty consistent from what it was when you were training?
Oh, technology advances all the time. So we upgrade our system, both intellectually, skill-wise, and technology-wise. I think if you have, let's say, an iPad or laptop, iPhone, you upgrade them every 2-3 years, same. So we update our software. We recently bought a new machine. Things always advance, and all the company, obviously in their financial interest, they always make things better.
Sure.
To get more accurate data reading.
Where do you see technology going? What's the next evolution?
It's hard to say, controversial right now. I think with the whole AI.
I'm dying to ask you about it.
Hey, AI coming, I think it's right now in the very, the early phase.
Yeah.
So it's still a lot of hit and miss.
Yeah. Is AI an aspect of your practice?
So what AI does is give you more information. So I gather a lot of information. For me, I used to enhance my knowledge. Let's say with the patient report and all the data interpretation, everything coming from my head, I use AI to, when I study, I use my AI to organize information, review them, and expand my knowledge. Let's say case in point, before I do a question, different answer, I don't understand something, then I have to flip through like different textbook or go online, search for different article to understand why that is or that is not. But AI kind of give you the information right away. They give you 10 more additional source. So everything's organized and focused on what you're looking for and the thought process. But I would not rely on AI for the outcome and the well-being of the patient. I don't think we're there yet. Hopefully we'll be there in 10 to 20 years. I would say 70 to 90% is great, but 10%. But when you talk about someone's livelihood and their functional outcome, like that's their whole life. That's 100% for them. So it's my responsibility to make sure I do the best I can for them.
We've heard about AI hallucinations when the information gets all jumbled. I know I've seen a little bit of that in my own research. Yeah. Have you seen that in a medical context?
Not so much with medical. So far, it's pretty consistent with my training from what all the questions I ask. But I look up a couple other things, and then sometimes they can be a 10x off from a certain number. Yeah. I think we were talking about like from baseball and like with stock and things like that. So they can be off. Yeah.
Yeah, I'm very interested in the technology. I'm curious to see where it will go. It's an exciting time.
Yeah.
But also caveat emptor, proceed with caution, because sometimes you can get something totally haywire.
Yeah.
Which I also kind of enjoy because there's kind of a funny Dadaist, mischievous aspect of it.
Yeah. My thought process is as a provider, I do my best to keep it updated and enhance my knowledge to continue to serve the patient, because I think that's the expectation. You want to go to the doctor, he's doing everything he can to make sure he know the latest, and he trying his best to treat you, versus like kind of do the same thing, like a cookie cutter of everything. So I understand that. So that's why I keep pushing myself to learn more and more about what can I do to better keep refining my art, my practice.
Yeah. Well, Dr. Ngo, you are a lifelong student, and it's appropriate that you're also teaching students and medical students and residents. Is that correct?
Yes, sir. Yeah.
So tell me a little bit about that work.
Oh, I enjoy it. I told them, most of the resident, you come. I asked them, I challenged them for the first, I would say, 2 hours, and keep them interested, ask them questions. And I think make it memorable for them. I told them, once you graduate, you have a whole life. it's going to be long hour hard work. So I'm here to make it fun for you the best I can.
I often hear these stories, kind of old guard attending physicians who were like the gatekeepers, and they would crush the med students, and you know what I mean? They were super disciplined and super strict with them, and any little thing that was out of place, they'd just come down on them. You're not that kind of guy.
No, those are the kind-hearted people. They care about you. I look back, so think of me as more like the cool uncle in the program. I think like the uncle at a party where like your parents are the one responsible for you. I'm just here to make it more entertaining, fun. Like we talk. So one of the things I remember when I was in training as a physician, and then when you resident, you're actually a doctor already. But when you're a medical student, one attending always go, future Dr. No, when I was a medical student at that point, like you're taking your board, a bunch of student loans, like a lot of things go through your head. And when someone kind of give you the belief or like the encouragement in the more subtle way, it kind of go a long way. Yeah. So that's what I'm trying to do with the resident and the student, because in a way, I told them, hey, if you have a full family, you come. I'm not gonna keep you here for a long time, and then because I'm more elective rotation, I think it will be different if I'm a core rotation, because core is in all the one that you have to notice. So we have the family resident. Most of them rotate with me, and some medical student, PT student. So they're more observer. They're here just to see what I do. So I try to be informative, entertaining, and build rapport with them. Yeah. To kind of help them with the next step, whether reference letter, rec, whatever they need from me. Yeah, so that way. Yeah.
What are some of the core lessons you want them to leave this experience with?
Yeah, so what I'm trying to impart onto them is, number one is the clinical knowledge behind the thinking process. I have them observe what I do, and I ask them questions along the way. Number one is the data gathering, the thinking through the problem. If they don't know an answer, I ask them to look it up, gather the data, and I ask them to present from me and trying to refine their thinking process. That's the art where it doesn't matter what specialty, I think they can hone in on and for the rest of their life and learn to be more efficient. You cannot be working for any place and see only 1 or 2 patients a day. So there's a lot of requirement behind the whole practice. So I'm trying to piece by piece, put them together for them. Yeah. And I treat all of them like my younger brother. He used to train here with me. He was my tech in the past. And he's a neurologist now, especially. He practiced in Northern California. So my point is, what I did for him, I do the same thing for the resident. And I talk to him about contract, like what to look for, and some of potential pitfall, and the practice pearl, like what you're trying to do to make sure you don't get into any legal issue with the problem with the patients, and like whatever I can do. And then I always put a precaution, I guess, like, hey, this is how I practice, but I show you everything, and then you just pick and choose what's best for you. You like, whether you don't like it or you might not see it now, is up to you.
Well, Dr. No, you said that we've talked to him maybe 5 times, and there's a reason. It's just always a pleasure to catch up with you, and thank you so much for your time and your expertise.
Oh, you're very welcome. My pleasure. Thank you for having me.
That is Dr. Thien Ngo. He is a physiatrist at KRMC Physiatry. For more information, you can call his office at 928-681-8693. That's 681-8693. And that is the program. That's another edition of Focus on Your Health. I'm TG Lafredo, and thank you for listening. We'll catch you next time. How do you say thanks in Vietnamese? I should know.
Cảm ơn.
Cảm ơn?
Yeah. I would say like, cảm ơn.
Cảm ơn?
Yeah.
That's perfect.
Yeah.
Like a native.
There you go.